which we now have better understandings, and then very quickly address venous injuries. So who do we investigate? Well, if the patient has hard signs of trauma, in other words, there's hemorrhage, they have a thrill, a bruit, or an absent pulse, or they have signs of excessive bleeding, which is indicated by a blood pressure of less than 90 millimeters mercury, or difficulty keeping this, or some other evidence that they're hemodynamically unstable, then we believe that an operation is required immediately. We transfer those patients out of the emergency department into the operating room. And when we're in the operating room, we do the following. Firstly, we resuscitate using standard protocols. Our protocol is defined within the ATLS guidelines. And then there are very standard principles of surgery, wide exposure of the injury, early venous ligation to control difficult bleeding from veins, proximal and distal arterial control, early consideration of damage control, essentially in severely injured individuals. In our teaching platform, individuals are expected to stay on the table for less than an hour. They will then be transferred back into the ICU where hemodynamic stability and other physiological stability is sought, and then go for possibly multiple definitive operations. The arterial repair needs to be tension-free. When we are unable to do that by primary anastomosis, we use grafts very liberally. The saphenous vein, if the saphenous vein is present, must come from the uninjured limb and must have the appropriate size. Otherwise, we use prosthetic grafts. And once we've done a repair, we want to have adequate tissue cover. So there's really no argument about that in terms of the principles of managing vascular trauma. What about this situation, however, here? A middle-aged individual shot through the arm, hemodynamically stable. Do we want more information? And clearly, you see that there's an injury here, and clearly the chest X-ray tells us that this individual has a thoracoabdominal injury, which probably takes precedence over what is happening in the arm. And if one hadn't got this information and had gone to the operating room to fix that arm alone, one may well have suddenly found oneself in some trouble. So, in our view, we need to investigate when there are, from a vascular surgical perspective, when there are soft signs of vascular trauma. And this is based on a high index of suspicion, based on the mechanism of the injury, proximity to significant arteries, and we believe that the Doppler pressures in an emergency room are very helpful, and if the pressures are reduced to less than 90% of the normal, then we believe that they need to be investigated. But I believe, and this is a view that I will support with a few cases just now, that there should be a liberal use of investigation, because there is significant morbidity associated with occasionally missed arterial injury. And the evidence there is of unnecessary exploration in these young individuals for suspected arterial injuries, in fact, is associated with a low morbidity and mortality. This is the picture that I want to illustrate this with. This is a patient that we saw about 4 years ago, hit by an ice hockey stick in his neck, was sent home from the casualty. And the first we got to know about it is when he developed this very significant stroke, which was as a result of a lesion in the origin of the internal carotid artery. And when we then explored it, that is what you saw. And if one had taken this young man and looked at it, this man unfortunately in fact died from that cerebral injury, and had done a simple investigation, probably just an ultrasound examination in this situation, but in our setting it's very easy to get a CT derived angiogram. This would have been avoided. The role of CT angiography in trauma is well established. I recognize that this requires a CT in close proximity to the emergency room, but there's lots of evidence that this is as effective as angiography in the trauma situation. And if you have this kind of capability, I can only commend it to you. In terms of what you see on that imaging, in vascular trauma, there is no such thing as vascular spasm. Be very suspicious of it. Here again is an example of a gunshot injury in the shoulder, resulting in what looked like vascular spasm, was diagnosed as vascular spasm by the individuals who were treating the patient until they showed us that angiogram, and that in fact was the lesion that was seen, and that was what we took out of it. If you are not able to do a CT angiogram, I would suggest to you consider doing single-shot emergency room angiography. This has been the standard that we used before we really had good exposure to CT angiography, and what we do is we do a direct puncture into the artery, single shot using a C-arm or a fixed X-ray facility within the emergency room with a region of interest in the site of trauma. The damage control philosophy, I think, as I've pointed out to you, has now become the standard by which traumatologists treat patients. And this, in fact, was the patient that I showed you with the gunshot injury, where the traumatologist had placed a nasogastric tube over the artery, giving themselves a lot of time to fix that artery and sort out the liver before he needed to, the hepatic injury that this man had, before they did a definitive repair of that brachial artery. The endovascular treatment in the use of trauma is now, I think, well established. Our colleagues in the Stellenbosch area have published quite extensively about it. They've demonstrated that this is a very feasible way of treating patients in some circumstances. They have to be used in stable patients, and certainly one of the limitations we have within the Johannesburg environment is that we often need specific equipment and specific radiology, which doesn't always make it possible. And in view of these limitations, we believe that it should only be used when surgical access is compromised. And here just two patients that I just want to show you here, a now slightly older vascular injury to the subclavian artery that Jay fixed over 10 years ago using an endovascular approach. This would have required probably a sternotomy in this patient. And this interesting knife wound, that was a patient that was treated by our colleagues in Baragwanath Hospital. They had preoperative imaging on a CT angiogram, and you can see that the internal carotid artery appeared to be impinged on just below the base of the skull. They believed that they could get surgical exposure, and that was the level of surgical exposure, and you can see that the bleeding continued. Professor DeGiannis, who's the head of the trauma unit in that environment, a very experienced surgeon, was just not able to get to that. And this was then the final result that they presented to our vascular colleagues at Baragwanath Hospital, and a small covered stent was used to stop that bleeding. Injuries to the cervicothoracic region are very dangerous. They're associated with a high degree of mortality. We have very little information about their appropriate management, and there have, however, been some probably intuitive changes to the way that we manage these patients. Firstly, they have to be managed aggressively in the unstable patient. We do like imaging them, and we do have a very low threshold going towards endovascular therapies, particularly injuries in Zone 1 and in Zone 3. Zone 2, in our opinion, is still the ambit of an open operation. The area that we're particularly interested in, I already showed you that false aneurysm in the subclavian artery, but our view is that any injuries in this region here require sternotomy. There are far too many people who try and control that from above and then lose the patient to hemorrhage because they've not gone towards that sternotomy. One of the tricks that we've learned from our colleagues in Cape Town, is that one places a Fogarty catheter through these wounds and pulls it, inflates it and pulls it up. That often is able to control the bleeding, particularly from venous structures. And in their experience, 9 out of 10 of these wounds eventually get controlled. They take them 48 hours down the line to an angiography, and only then repair if they find very significant arterial injuries. The reported evidence in this situation is 18 patients, and as you can see, there was only one rebleed that required surgery. This is really just to illustrate the issue in terms of early stenotomy. Talking then about blunt carotid injuries, I think that the data that we now have in this regard gives us a much clearer idea of what to expect. This is work that was done in Denver, in Colorado. And essentially what they did is they developed a grading system that looked at grade 1 being mild intimal injuries, of which the vast majority get better without any treatment. Dissections or hematomas where there is at least an impingement of 50% of the luminal diameter. Most of these progress and despite the use of heparin often also result in stroke. Grade 3 injuries are false aneurysms which have to be treated. Grade 4 and 5 injuries tend to be very severe injuries and are mostly fatal. The big thing that we've learned from the experience that comes out of Denver is that anticoagulation dramatically reduces the risk of stroke in these individuals. And for this reason, our approach to any form of significant carotid injuries, we're not talking grade 1 injuries, is to anticoagulate these individuals, even if there are other injuries available, or other injuries, as long as we don't get any uncontrolled hemorrhage. So this is what we do now. For grade 1 injuries, we anticoagulate, often now using antiplatelet agents. Grade 2 injuries, we repair if we can get to them. Otherwise, we use endovascular approaches. False aneurysms, we use endovascular approaches. When the artery is occluded, even if the patient has already had a stroke, we just anticoagulate. We do not think that there's any benefit of revascularizing. And we have as yet not seen a survived transection. Vertebral artery injuries are, I think, quite an interesting additional injury. We all have read the textbooks of how one supposedly fixes these. This today, on the basis of the information that we have from the Capron unit, in our opinion, needs embolization. The important aspect is that embolization needs to occur above and below the lesion in the vertebral artery. Finally, very quickly to talk about vein injuries, and this is again an experience that mostly comes from our colleagues in Durban. There is no quality data, and most of the data is a personal bias, but we do believe that when a vein is injured and is repaired, that very few of these remain patent over any period of time, and that if you follow these patients over a long period of time, that they're very modest sequelae as a result of the injury to the vein, whether it has been ligated or it has thrombosed. The other is that we've often seen patients or individuals trying desperately to repair veins and often finding that these patients then have inappropriate levels of hemorrhage and are put at risk. And the work that comes out of the Durban unit is that ligation of venous injuries, if it is at all required, is safe and is probably saves lives, does not increase the risk of amputation as long as there's a liberal use of a fasciotomy. So we, in stable patients, will repair an isolated simple injury. The rest will generally be ligated, but as I pointed out, many of these patients will then have a fasciotomy that is probably done preemptively. In unstable patients, all of these patients' lesions really just get ligated. So in conclusion, colleagues, I believe that the management of vascular trauma today requires aggressive resuscitation in our view, in our unit using ATL principles, but it doesn't matter what principles you use. We believe that early aggressive surgery using a damage control principle in a physiological compromised patient is important. And we are of the view that one should be using some form of angiography, be that with computerized tomography or with an emergency room angiogram in stable patients. Our view is that under-evaluation of these patients causes significant morbidity and occasional mortality. Thank you.
If you don't mind, I think we just take the last few lectures quickly and then we pull all the questions. I think you're next.
I'm going to talk about something completely different now, approach to dialysis access, which is the need when patients reach a GFR of less than 15. So in some of the patients, end-stage renal disease is a need for dialysis, and that's the access facility in South Africa is the behest of the vascular surgeon. What are the options? Well, you can create a native arteriovenous fistula using a native vein, usually the cephalic vein in the arm. You can perform a graft AVF, which means using synthetic material, usually PTFE, but Dacron is sometimes available and cheaper. And at some point in time, then a central venous line may or may not be necessary. This is using something called a permanent catheter as opposed to a temporary catheter, and there are some differences. And this is the situation that we are faced with more often than not in South Africa, and it's not the ideal, and I'll explain to you why just now. But if a patient needs imminent dialysis, so he's been in has kidney disease for a period, suddenly find that he needs to be dialyzed, then we get referred the patient a day or two before the dialysis is required. And at that stage, we perform a simultaneous procedure of creating, if at all possible, a native fistula using a cephalic vein, and at the same time insert a permanent catheter into the internal jugular vein. The native fistula, if it does work, will mature in about 6 weeks, at which time you can then use the fistula, and then we will remove the permanent catheter. Ideally, what you want is for the patient to be referred to you 2 months prior to the dialysis requirement. In other words, if you can create the AV fistula, not having placed the central venous line, that's the ideal situation, but it's not always possible. The preferences vary amongst countries, and this is something that I don't understand, but the DOP study was published or started recruiting patients in 2000 and published it in 2002. And then subsequent to that, published a second paper in 2004. The end point of the study was very clear. There are inherent differences between North America, in other words, United States and Europe. In North America, up until today, about 70% of patients are still treated primarily, in other words, the first dialysis instance, with a graft. And as opposed to Europe and in South Africa, we still are on the side of using native vessel. I'm not sure why that is so, because the data is overwhelming in favor of AVF as a superior as first access, and you can see this. There's better patency. At least 17 papers are published on this, some of them randomized controlled, and others are case reports. The survival, if you use a vein early on, is better. That's not only related to the fact that there may be sepsis with the graft, etc., but there tends to be better dialysis volumes if you use vein as a first choice. The second DOP study, published in 2004, stated very clearly that a permanent catheter placed into the internal jugular vein is associated with cause-specific mortality. So in other words, if you place 100 of these and one goes haywire, the patient can die on the table, and this is where this comes from. So the aim of what I want to do in the next few minutes is to indicate the technique of a permanent catheter insertion, and this needs to be done in a very specific way to avoid long-term morbidity. Then if I can, I'll go through the technique of a native arteriovenous fistula creation, and then look at some of the complications of these things. So a permanent catheter is distinguished from a temporary catheter by the fact that it is cuffed, so there's a little Teflon cuff that prevents, or said to prevent, infection and fibrosis to the skin. And as opposed to a temporary one, it needs to be tunneled for about perhaps 10 centimeters from one point, from the exit point to the vein access point. We tend to use a pre-curved catheter as opposed to one that is straight that you need to refashion. And we use one with a simple assembly. Now there are ones that you can cut the length and join together and then place some hooks onto it, etc. They all do the same thing and cost the same amount. But the simple one is one that you can place fairly quickly, and you don't have to judge the distance into the right atrium. The pre-curved comes in two lengths. There's one that's 19 centimeters that you use through the right side. So the right brachiocephalic access, and the other is about 23 or 24 centimeters that you can use for the left side due to the longer length to enter the right atrium. You can do this under general anesthesia or local block in the neck. So some of the tunneling can be done purely with local anesthesia in patients who are overloaded or too sick. You start by placing them into a head down position to fill the veins. You make absolutely certain that you puncture the vein the first time. I'll show you what the jugular notch puncture is. So we don't go too high into the neck. This is actually done at the junction of the clavicle. And this is very important. You avoid any other vein in the area. So puncture in the subclavian axillary femoral vein for perm cath is just not on. It creates sepsis or creates stenosis in a vein, and the subsequent fistula is then hampered by the stenosis. When it's first inserted, ensure that there's no resistance to wire passage. If there's any sort of resistance, then you may be in a normal vein, and that can create problems. So this here is, well, the clavicular notch. And that's what we aim for. This is a sternal notch, so just to the right of that, you can always feel this. And if you insert the catheter into that point, then there's a very nice curve running down adjacent to the sternum to which you can tunnel, and the curved part just slips into it. If you go too high, then it's too acute, and if you enter the subclavian vein, then that just creates stenosis and problems later on. So this is what we want to do. So you want to puncture it just there, so it's between the heads of the sternocleidomastoid. But note that your wire, if you are blind, can pass into the subclavian vein in that direction, can pass into the azygous vein, or can even go up that way. And that has happened. And if you pass the big peel-away sheath in that direction, so if the wire follows that direction and you pass the peel-away sheath there, you can nick the vessel here. Patients present with a massive hemothorax, and that's when we run off to the cardiothoracic surgeons to help. And anybody who's done quite a few of these would have all had those complications. So we use what I would call ancillary monitoring. There are times when we puncture the vein under ultrasound. This is not a usual practice for us, so we've sort of got used to it. But there are centers that use a handheld sterile ultrasound to actually puncture the vein initially. When the wire passes into the heart, this is a very important sign. Your ears are open, so if it passes and you hear ectopics on the anesthetic machine, you know you're in the right place. We have of recent, over the last 3 years or so, routinely done this under fluoroscopic guidance. So there's no venogram done routinely, but we pass the wire into the heart, then watch the wire move with the rhythm of the heart, and you know you're fairly safe. And this has not been shown or challenged in terms of scientific literature, but once you have a tear of a major vessel and you have to perform a stenotomy, you'd always rely on this sort of thing to be absolutely safe. Complications, as I've just said, major vessel rupture. It's not uncommon. If the catheter is left in for a long enough period, it will tend to form some clot at its distal tip, and then will be non-functional. And over time, you can have some sort of trauma, intimal hyperplasia of that vessel, and stenosis, which will prevent working. And of course, this is a major problem. We have lots and lots of patients who have what we call access failure. In other words, it's almost impossible to create an AV fistula because all of their veins have been used. And infection under these circumstances is undoubtedly life-threatening. So catheter sepsis from gram-negative sepsis is extremely important. In terms of brachiocephalic fistulae, vein anatomy at the level of the antecubital fossa, and that's what I want to discuss, not the Brecia type operation at the risk. Sometimes difficult because vein anatomy is variable. The access vein, in other words, a vein that you're going to insert the needle to, or the nephrologist inserts a needle to, must be one that's very superficial. And the one that we use is the cephalic vein. And we see general surgeons performing this operation quite often, and they find any vein, so deep vein, and they'll connect up the vein and the artery, and you'll have a fully functional fistula, but the vein is too deep, so therefore it doesn't work. Remember that there are valves, and there's an anatomical picture I'll show you just now. So you remember that the valves flow from distal towards the heart, so keep that in mind. When you do the anastomosis, make sure that the vein in that area is not kinked. Often the artery is deeper than the vein, so you can have kinks as it twists around muscles. And check for a patent cephalic vein. So in other words, sometimes it flows up the mid-arm and it's stenosed in that area, and it's likely to fail if this is not checked. Well, this is the right antecubital fossa, And this is the cephalic vein. So this runs under the skin all the way up the arm and then dips down into the deep vein as it enters the chest. And that's what you want to connect to an artery which is lying somewhere there. Now this basilic vein is superficial in this part of the arm, but it's deep here. So it really goes deep and travels with the artery in that arm. And you can easily connect the basilic vein to the artery, but that's a non-functioning fistula. So what you need to do is dissect this out and connect this to the artery at that point. So there's quite a bit of distance that you sometimes need to travel. So you go from there to there, and if that works, then you have a fistula traveling up the arm, which is easily accessible. Now, this median cubital vein, remember, blood flows from that direction into that direction. If you cut the vein here and connect it into the artery, there may be valves at that point, so this will fail. And I've seen that quite often, so it's just very easy because it's quite a big, robust vein. Remember that the artery starts somewhere here, and at that point goes deeper and is medial, so it's easier to connect it where it's close by than actually doing it further up. So that's the artery, and you can see how it twists from medial to lateral, and it is somewhat deeper, and all you want to do is swing the vessel around from here onto the deep artery as an end to side anastomosis, and cut the vein off here, and that should work, providing the cephalic vein is of adequate caliber. The diameters that have been published vary from about 2.5 millimeters for adequate patency to about 3. So I think if the vein and artery are an average of 3 millimeters, including those that you may want to do around the wrist, then this should give you a reasonable result. This, we think, is an important feature of a successful fistula. Once performing it, if there is a pulse, what we call a hard pulse, then there's likely to be an obstruction in the vein further up, and that fistula is going to fail. But an easily felt throat, in other words, if you can feel this with your fingers or afterwards with a stethoscope, means that there's direct flow from the artery all the way to the heart, and this indicates some sort of success. It's become a habit to palpate the distal pulses. Sometimes you can have a steel, or you can have an occlusion at the site of the anastomosis, and that can lead to problems later on, in other words, ischemia of the hand. And I think that's really important to check that the pulses are still there. Early complications, well, you can have failure, usually related to some sort of technical problem with the anastomosis. Non-maturity is not uncommon, and that behoves the fact that veins may be very small and they sometimes go into spasm. This is uncommon, but you can have a steel, particularly if you use the PTFE grafts, which are very large. So you'll have a large amount of blood flowing from the arterial system into the vein. And usually they present over 24 hours or so with severe ischemia or pain in the hands. And it's probably safer under those circumstances take down the fistula than try and do something else. And you can have these common things from poor technique, so nerve injury, in some areas hematoma, false aneurysms, etc., that you find with other forms of vascular surgery. Well, late complications, this has been a feature of our unit in that we deal with complicated access cases. If in a fastidious unit, what they would do is monitor these by checking on dialysis pressures. So if the dialysis pressures goes up and the quality of the dialysis deteriorates over time, there's likely to be some sort of obstruction to flow. And that, for duplex ultrasound, usually there are figures which I'm not going to go through that indicate a successful or non-successful or fistula that's going to fail. The majority of these problems, so when there are fistular problems, are due to either a peripheral vein or a central vein stenosis or occlusion. And that could be due to a permanent catheter that was placed previously, or it could be due to intimal hyperplasia. And the majority of these, so superior vena cava angioplasty and stenting, cephalic angioplasty and stenting, are probably best achieved via endovascular means, and a lot of them are in the chest. And there's relatively good data today to suggest that we should be using covered stents, or stent grafts, rather than open stents to treat this. Intimal hyperplasia tends to recur if you use a nitinol open stent. Again, it's an expensive strategy, and you often have to go back 2 or 3 times a year to keep these fistulae open, but it's well worth the effort in somebody who's dependent on dialysis. I'm just going to go through how we, more often than not, perform a graft insertion. In other words, not a stent graft now, but placing a piece of PTFE when vein or native vein isn't available. So this is probably not the best picture to show you, but this is the left arm again. And what we do more often than not is to take the access point from somewhere there. So if there's a scar here from a previous native fistula attempt would go slightly higher and use this as the arterial access point. The vein, the deep vein, which is a basilic vein, would run in that direction. So all we'd do is take a piece of PTFE and tunnel it very superficially under the skin in a gentle curve and then plug it onto a deep vein. So it's a deep anastomosis there and a deep anastomosis here, but the bulk of the Dacron or the PTFE is probably the graft of choice, is quite superficial. You can plug it on there or even higher, and of recent we've been placing it quite low, and there's a good reason for that. If that fails, then we can go on the outside of that and take it even higher, so it gives you a bit of longevity in terms of access management. So in summary then, I think there's, despite what you're going to read about that's coming out of the Americas, a fistula first, using native fistula is the way to go, and there's mortality benefit in doing this. Chronic venous lines need to be monitored for infection and thrombosis. An assessment of vein and artery is extremely important before creating this. And I think an access team, in other words, if you're interested in this, you need to get a group of people together that have some interest in doing these things properly. And that would lead to a fair amount of experience and success for this technique. Thank you.
Well, last but not least, Dr. Ndiaye from Senegal.
Thank you, Mr. My talk today is about how we did implement vascular surgery and endovascular in Dakar. It was a long way. Venous and lymphatic disease were neglected, and to solve those problems, training has been organized by our teachers. Before 1809, we did only amputation and repair for vascular injuries, like you saw it later. That should be available everywhere. Then we went to training in Erasmus Hospital, where we have been taught the techniques of vascular surgery with the beginning of the endovascular, but mostly it was the technique of endovascular and distal revascularization on diabetic foot and limb ischemia, critical limb ischemia. We published what we have learned from diabetic foot over there. From 89 to 94, we returned back in Senegal and tried to implement what we have learned. It was very difficult. We were able to do femoral popliteal bypass if the Doppler showed us a femoral patency and flow in the popliteal artery. But some of the time it was not going on because of infection and sometimes failure. But we needed to keep the activity. Cardiovascular diseases are common in Senegal. Actually, in our department, we have 16% of elder patients, more than 60 years in our definition. Their mean age was 72 years. We found out that tobacco was 16%, diabetes 55% incidence, and high blood pressure 32%. So the cardiovascular surgery, the cardiovascular diseases are now in Senegal, in adults, the first cause of mortality. Professor Diop will not say the contrary now. So we are facing a big burden. When we look at the pathologies in the department, our activity is separated between 65% vascular, 25% thoracic, cardiac 2%, and over 6. This says that vascular surgery is very important in our practice in these countries. When you look at the lesions, aorta-iliac, in the angiogram and all the patients we have treated is 11%. Most of them are critical limb ischemia with femoral popliteal and distal lesions and peripheral arterial disease which should be treated. We have only 8% of aorta-iliac lesion, which has aneurysm and Leriche syndrome. In the beginning, we had a diagnostic angiogram from 1994 when we were at Le Dantec Hospital. This angiogram was used with, was done in the OR with the C-arm, and it allowed us to take care of better care of patients with diabetic foot, revascularizing the people who needed revascularization, and also wound care, which was being done more appropriately because of the appropriate revascularization. From then, we did more revascularization, better care of trauma. We published all this, and femoropopliteal bypass for critical limb ischemia, that has been also published. Femoropopliteal bypass for us can be trained. People can be trained, and it can be used very, very widely in general surgery department to allow people to salvage more limbs and reduce the amount of amputation in atherosclerotic patients. Abdominal aortic aorta has been interesting. We did subrenal abdominal aortic aneurysm. We are operating a series that we have published. The diagnosis is now easy because of CT scan. We can manage to it, and the operation is not very difficult if you have good anesthesiologists to work with us. Sometimes we need to use a tube. Most of the time we use a tube, but sometimes we do, like in this case, a bifurcated graft. Varicose vein and surgery. We did a study in 2000, it was in the 90s, but we published it in 2004 again, about leg ulcers. Dr. Bella said earlier that venous disease was supposed not to exist, but most of our leg ulcers are related to venous insufficiency, but we don't know it. But when we started to use compression therapy, we found out that we were able to cure very quickly the leg ulcers. And this was the proof that venous insufficiency was responsible of some of those ulcers. We published also on varicose vein surgery that we did very quickly, and deep venous thrombosis also is sometimes observed. And there was a multinational study which has been done 4 years earlier, deep venous thrombosis safety zone. It was sponsored by Sanofi Aventis, and this one-day short survey showed that every day we have people with deep venous thrombosis in the medicine department and the surgical, orthopedics, and gynecology department. And if you look at it, we will find them. And the prevention is very important in deep venous thrombosis. So vascular malformation also is a concern in vascular surgery in Africa, because parents most of the time are asking for a good treatment, and sometimes it's not very easy to cure those patients. Some lesions are accessible to surgical resection, but some of us are more tricky and need hybrid treatment. Arteriovenous fistula, most of the time, unfortunately, patients come to us after having started dialysis with peripheral catheter or a central venous line. But we are asking people to help us send the patient before they get to dialysis, but it's not very easy in Africa. 84% of the fistulas we did were distal. We use wrist more than brachial fistulas. Well, it is a choice, but sometimes in men it is easier. But in female, most of the time we use brachial fistulas because the veins are too small and sometimes they are not very successful. This is a brachial lesion. We use the cephalic, that like you see, and ligate it all the derivative to be sure that we have a good direct flow. by 95, we had already implemented most of the activities I have been talking, and we were thinking at that moment that it was time maybe to solve more problems to get a training in endovascular horizon. We were doing emergent operations. We had already three surgeons which had been trained. And I went to Arizona Heart Institute for training, for a fellowship, during a fellowship to have an hands-on training. And during that trip, I did a study on carotid stenting on 110 cases, but the failure was high because of intimal hyperplasia. We were using Palmer stents at that moment, and it was not the best treatment, but it is a good experience. And now carotid stenting is improving, but did not arrive at the level of carotid endarterectomy. When I came back, it was always the same thing. We didn't manage to have the opportunity to implement everything we had in the hands, but it was the time we were building the cardiovascular and thoracic system. So we were not very frustrated not to be able to do endovascular procedure. But we were working in a new facility, and when we had it, we decided to send another surgeon to be trained. In the new hospital, we had a new C-arm. We have also in the hospital a 64 slice angio scanner, which helped us a lot in the diagnosis. And we have also help from a friend from Arizona who gave us gifts and came to a mission in Dakar to train the personnel. Then after that, we sent a second surgeon to Arizona Heart Institute who had a more complete training for 18 months when he came back with open vascular and endovascular skills and a quantity of donated supplies. And we can say that the first launch of endovascular was in 2008 with iliac stenting, peripheral angioplasty, and peripheral SFA stenting. That was a strategy used in completion with the open surgery for the treatment of critical limb ischemia. We have not yet arrived to the stage of the abdominal aortic. Hybrid treatment of anterior venous malformation also have studied. We first embolize and then do surgical excision if it is possible. But it's very difficult. But sometimes we were successful in reducing the amount of blood lost during the surgery. And now the companies get interested in endovascular supplies in Senegal. And now we have been able to get sheath, angiocaths, balloons, guide wires, and so on. We did also training for the people for endovascular because it is a team effort. We cannot train only the surgeon, we need to train the personnel and the other surgeons and give advocacy for the administration to get the supplies, because when you take it globally, it is cheaper to do peripheral vascular than to do open in some cases, because the patient goes home very quickly and some complications are avoided. We have this, you see there the C-arm we are using. The C-arm technician have been taught with the principle of radioimaging, radiation protection, digital manipulation, vascular anatomy and pathology, and the different steps of an endovascular procedure, and now he is autonomous. The OR nurses also have been trained, mostly in the reusing of the supplies. Because we are very poor, we cannot afford to use single use. In the beginning of the hospital, we had ethylene oxide sterilization system, and we use it to re-sterilize the supplies after decontamination, conditioning. We use gas sterilization and reuse it until it breaks. We did not invent that. We saw that way of doing in different places in the world. So we continue doing it, but maybe it will be very pleased companies, but we have no choice. The future goals are to do more complex cases and get up to thoracoabdominal or to abdominal aortic aneurysm, by endografting, and then maybe higher if you have the opportunity, to initiate a multi-specialty team for limb salvage with radiologists, vascular medicine, and cardiologists, because it is important to make people aware of the positive diagnosis of critical limb ischemia and even acute limb ischemia. I don't know if it is the same here, but sometimes, most of the time, people come late because the diagnosis was not made. They see the doctor the same hour of the beginning of the pain, but the doctor did not recognize because he only did not touch the pulses. By touching pulses only, you can make the diagnosis of acute limb ischemia. But most of the time, they wait the day after, and sometimes it is too late. So that's why we were thinking about the multi-specialty team. The perspective also is a training program for vascular surgery, which should be accessible to our colleagues from West Africa, and give basic skills in endovascular to radiologists, nurses, and technicians. This will be